We have a very good question here. How do we differentiate between type 1 and type 2 diabetes mellitus? Sit here and we learn. Don't go away. Distinguishing between type 1 and type 2 diabetes is primarily clinical, supported by age of onset, phenotype, metabolic state, and laboratory investigations. In real practice, overlap is common, especially in adults. So diagnosis lies in a combination of features rather than a single finding. Now let me begin with the differences that can help you to diagnose either type 1 or type 2. Number one core is the pathophysiological difference. Let me begin with the type 1 DM. It is as a result of autoimmune destruction of pancreatic beta cells, and this leads to absolute insulin deficiency. But when it comes to type 2, it is as a result of insulin resistance with progressive beta cell dysfunction. This eventually leads to insulin deficiency. Difference number 2 are the clinical features that may help you to differentiate type 1 and type 2. In type 1 DM, usually childhood, adolescence, or younger adulthood, and it is acute on onset. In type 2 diabetes, it typically occurs in age greater than 30 years, though it is currently increasingly seen in adolescents due to obesity. When you look at body habitus, people with type 1 may have lean or normal body weight, but in type 2, they are overweight or obese and often central obesity. Another issue to consider the clinical presentation. In type 1, we have rapid onset of polyuria, polydipsia, and weight loss. When I talk about polyuria, I mean frequent urination. When I talk about polydipsia, I mean frequent thirsty. These people all may present with DKA, diabetic ketoacidosis. But when you look at type 2, it is always asymptomatic in early stages. They always present with symptoms of fatigue, recurrent infections, blood vision, and may present with hyperosmolar hyperglycemic state, or what we call HHS, in severe cases. When it comes to treatment, type 1 requires insulin from the time of diagnosis, whereas type 2 is initially managed with lifestyle, medications, plus or minus hypoglycemic agents, though insulin may be required later if the above have failed. When you look at family history, in type 1, there is always less familial clustering, but in type 2, there is a strong family history. Another issue is the associated conditions. Let's look at type 1. In type 1, there is autoimmune associations. For example, thyroid disease, celiac disease, vitiligo, whereas in type 2, they always present with metabolic syndromes. For example, hypertension, dyslipidemia, central obesity, acanthosis nigrans. Those are the makers of insulin resistance. When you look at laboratory differentials, one, when you look at blood glucose, of course, both types show hyperglycemia, and this is not diagnostic of a type. Then two, when you look at ketones, in type 1, ketosis is very common, and which is a higher risk for DKA. But in type 2, ketosis is rare, unless severe stress or late disease. And another lab finding is the C-peptide. This is the key maker. In type 1, it is low or either absent. The C-peptide reflects endogenous insulin production. And in type 1, it is either low or absent. In type 2, it is normal or either elevated early, though it may decline over a time. Then in advanced laboratories, they are what we call autoantibodies. In type 1 DM, autoantibodies are positive. That is the GAD65, islet cell antibodies, IA2 antibodies, and in type 2 is typically negative. This is an important clinical question I want to bring to you. Some type 2 patients may present with DKA. Some type 1 patients may be overweight. Another question is the LADA. This is the latent autoimmune diabetes in adults. It resembles type 2 diabetes and slow the progressive autoimmune B-cell failure. So in a clinical approach, when diagnosis is not clear, assess BMI, age, and the clinical context I've mentioned. Assess for ketosis or history of DKA. Investigate HbA1c, C-peptide, and the autoantibodies if available, and always initiate insulin if ketosis or DKA is present, severe hyperglycemia, respective of the type, diagnosis is uncertain in a symptomatic patient, or either type 2 patient has failed to respond to oral antihyperglycemic.